What is up, guys? I'm back with another video, and today we're going to be looking at inflammatory breast conditions. So this is kind of a subset in a series of breast pathology situations that you can have presented on board exams or in the clinical situation or scenario. So we're going to break this down into various subtypes because there's a lot of diseases that you can begin to look at, syndromes and conditions, whatnot, in breast pathology. And so I have just decided to make the first video focusing on inflammatory conditions of the breast, and then we'll continue to some of these other ones. So under the classifications of breast pathology, you have inflammatory breast conditions, which we're going to cover today. So that's right here. And then you have benign breast tumors. That's going to be the next video right here. Then we're going to move into malignant breast tumors right here. And then we're going to have a short video on congenital breast anomalies, which you could have a random question that I think is pretty easy. But you could have a random question on it, and you don't want to miss a really simple question. So moving further, now we're going to look at the specific subtypes of inflammatory breast conditions. They are mastitis, breast abscess, periductal mastitis, mammary duct ectasia, and then fat necrosis of the breast. So let's get right into this. The first one is mastitis. So I always break the word down. If you know a little bit about what the word mast means, or another way of saying it would be masto, as a root word, it's just referring to breast. So what do we have here? We have masto or mast, so this is breast, and then you have itis, which always means inflammation of. So you have breast inflammation. So that's basically what's going on here. You're having a basic form of breast inflammation, but how does it happen? So the true definition of mastitis is just a bacterial infection of the breast parenchyma. Remember that parenchyma, whenever you see that, that just means the part of the tissue that's functional. So we're not talking about the connective tissue and the overlying skin that doesn't really have a function in the overall functioning of the breast themselves. We're talking about the lobules and the ducts, whatnot, that actually have a function in the transportation, production, and whatnot of breast milk. So we can have a bacterial infection within the lobule or the duct. So before we move further, I want to break down, because you're going to need to know this for all of these following inflammatory breast conditions. What do I mean by a lobule, a duct, and all of these terms? So if you think of the parts of a breast, so if we go inside a breast, and we're going to basically go looking down inside of it by layer, when you go a little bit deep from where the areola and the nipple is, you're going to notice, if you zoom in real close, you're going to see things called lobules. And these lobules is basically what's helping and assisting in the production of milk, which can then, of course, be used when you breastfeed the baby. So these lobules are deeper than what is going to be leading to the duct, what's called the duct of the breast. And then, as the milk collects and goes down the duct, it eventually will reach then the nipple and then can be given to the baby for nourishment. So these are the lobules, and this is the duct, or the ductules. You can hear lobules and ductules, or you can just call it ducts. So now that you know that, and remember this is deeper here, and then this is more superficial here. So now that you know that, there's going to be a lot of various inflammatory conditions that affect, whether it be the ducts alone, the lobules alone, or it can be affecting both, or maybe just more superficial than the ducts and lobules on more of the surface. So we're going to see different things. In this particular example, this is just kind of a generalized bacterial infection of the breast parenchyma. So it can be the lobules, the ducts, any part of it. And what actually causes this? Well, typically you're going to see this in breastfeeding mothers. And what happens is, as the baby is breastfeeding, sometimes as infants are learning to breastfeed, and kind of some of them breastfeed a little more forcibly than others, and then you can get what's called fissures. I have a video on anal fissures if you're not sure what a fissure is, so check that one out on my channel if you're a little confused on what I mean by that. It's basically just a tear, little tiny micro tears that are in the skin, and this allows bacteria to enter into these little fissure areas. And the most common bacteria that's coming usually from the baby's mouth or nose or skin is going to be Staph aureus. So that's the typical bacteria that causes that bacterial infection that enters into the fissures and then eventually can get into the lobules and ducts or the parenchyma of the breast tissue. So this is unilateral in almost every single case. Well, that kind of makes sense. If you have a baby who's breastfeeding, whether you're breastfeeding from the right or the left breast, typically you're only going to have an infection happen on one of them at any given one time. It would be very unlikely that you would have an infection of both breasts at the same time. So this is usually going to be unilateral. So that can help you to start to limit your diagnoses, because there's going to be some other things we talk about a little later on where they always present bilaterally. And so this kind of another little detail to help you to break down some of the different differentials. So what is the treatment for this? So I said that it's caused by Staph aureus. It's a bacterial infection that gets into the fissures and then gets into the breast parenchyma. What's the breast parenchyma? The lobules and the ducts. It's almost always seen in breastfeeding mothers. It's unilateral in presentation. And then the treatment. The treatment is the part that's kind of hard for me to remember. The rest of this, I usually can remember it. But the treatment is a little difficult. And it's kind of counterintuitive. The first treatment they're going to tell you to do is to continue breastfeeding. The reason is because as you get an infection and then follow up with inflammation, that happens when the bacteria enters the fissures and then gets into the parenchyma of the breast, you begin to have milk stasis. And any stasis that happens with the milk blocking the duct itself and then eventually kind of backing up into the lobule area is going to cause more and more infection that can become more serious and more deep into the body. So they're going to actually encourage you to continue breastfeeding. And this is actually okay for the child, because a lot of situations you can see if you don't continue breastfeeding, it can get far more serious. And then the other treatment they're going to do is give you antibiotics, a penicillin called dicloxacillin. Okay. How do you remember this is the particular first line drug given? Because the beginning of dicloxacillin says di, and a female has 2 breasts. So that always helped me to remember that dicloxacillin is given. Okay. So the next one is a breast abscess. This one won't take long. This is the main complication of mastitis. If you weren't, let's go back to the previous slide. If you don't tell the person to continue breastfeeding or you delay dicloxacillin treatment, you can then get a breast abscess. So this is usually almost always a result from mastitis in breastfeeding mothers. So this is just obviously what's the definition of an abscess? That's just a pus-filled encapsulation within breast tissue. And so we've covered this, and then we move to it presents as a fluctuant mass on physical exam. What that means is that if you were to see some sort of little like bump or bubble up on the breast, so say the breast was here and then you had this little raised area right here. When you put your finger right here or wherever on it and you press down on it, it will send that pressure from that area because it's filled with pus and various fluid kind of things like that. When you press down here, naturally there will be a reflex to kind of like a wave-like reflex, and it will go up over here through the entire abscess itself. This is called fluctuant. Basically, think of like in a patient who has edema in the stomach or like fluid in the stomach. So when you press on one part of it, it will naturally, the other part goes back up. That's what's defined as fluctuant. So that's the best way I can describe fluctuant mass on physical exam. So what's the treatment? The only treatment for this is surgical drainage to treat. Okay, so when it gets serious enough to be a breast abscess, then you're going to have surgical drainage to treat. I also want to emphasize something else. For all of these diseases we're talking about, so this is why I went back to mastitis. For all of these diseases we're talking about, we're dealing with inflammation. And you have to remember the cardinal signs of inflammation: redness, warmth, swelling, all of these type of things: redness, warmth, swelling, and then pain. Those are the 4 cardinal signs of inflammation. Because these are all inflammatory conditions of the breast, this can be present in every single one of these. So keep that in mind. If I don't tell you that there's redness in this condition, warmth, swelling, and pain, just remember the fact that we're dealing with inflammation should guide you towards the fact that, oh yeah, I could see any of these 4, whether it be all of them or even one, as these are the cardinal signs of inflammation. Okay, so we've covered now mastitis with the complication being breast abscess if not treated appropriately. Now we're moving into periductal mastitis. Periductal mastitis, I always teach you to look at the word. Peri means around or next to. Around or next to. Ductal, that's referring to the duct that we talked about. Remember, you have your lobules that are more deep in the breast, and then they're gathering the milk and making the milk, and then it sends it out through the duct. So we're referring to the duct here. So around or next to the duct, you're having mastitis. So that should intuitively make sense. So what is the definition of this? This is a bacterial infection of the ducts under the nipple, or sometimes you could say around. You'll often see it described as a subareolar mass. That's more or less, this really confused me, this particular point, and I'm going to explain why. When I saw a subareolar mass, I was assuming, when you look at a breast, here's a breast with the areola and the nipple. I was assuming, oh, the mass or the thing itself must always be underneath the areola. It must always be down here. That's wrong. You'll see situations of periductal mastitis where it will always usually be around it. It's not going to be on the nipple or usually on top of the areola. It's usually going to be somewhere around it, in the surrounding vicinity. But when you see subareolar mass, that's more or less talking about the areola area. It is deep to that. It's kind of deep to that, because there's a lot of situations where it is not sub underneath it per se, as far as if we're talking inferior. So this is more referring to deep. A subareolar mass is more referring to deep, although it is very common to appear underneath the areola area. Okay, so what is this? This is a bacterial infection of the ducts under or around the nipple. So what causes this? So what causes this? They pretty much know. In 90% of cases, 90%, so almost all of them, smoking is the primary factor. So what happens is a patient smokes, and when you smoke, the toxic metabolites and whatnot are lowering your levels of vitamin A. I want you to remember, I'm going to come over here. With vitamin A, one of its functions is to help differentiate epithelial surfaces. What that means is that if you have say you have a bunch of cells and they've just been formed, as they go to their appropriate spot, wherever that be, say it's on the skin of your hand or your leg or a particular organ or whatever it may be, as the newly formed cells that have just came from mitosis, as they kind of stack up and begin to get in their correct places, they then have to differentiate into the particular function that they're going to have on that epithelial surface, which gives the function of the organ that it's on, whether it be the skin or the heart or whatever it may be. As long as it's on a surface that particular organ doesn't have cells that will continue to regenerate through its whole lifetime. So vitamin A is really important for differentiation of epithelial surfaces. And that means without vitamin A, you begin to alter how the cells are appropriately supposed to function, look like, and then they can change into other cells that they're not supposed to be in. Supposed to be at that location. So let's go back to the duct. We're referring to the duct in periductal mastitis in this disease. I want to tell you a really high yield point, and that is that there's always 2 layers of epithelium, whether it be at the level of the lobules or the level of the ducts. In breast tissue, in the main functional parenchyma of breast, you always have 2 layers. The first layer is what's called luminal cells. Luminal cells. And luminal cells are columnar. Remember what columnar means? Just kind of like long, like a rectangle. Columnar, like a column. So they are columnar. And columnar cells have certain functions that other types of cells don't have. I'm not going to go into all the details, but they have certain functions, whether it be with reabsorption, secretion, or whatever, as you learn a lot in GI pathology and GI physiology. Underneath this first layer of epithelium, which is titled the luminal cells of this breast parenchyma, you then have a more flattened cell that's called a myoepithelial cell. The function, and just look at the word, myo means muscle, epithelial is just referring to the epithelium, so it's making up the epithelium. So this is just saying that this has a cell that has muscular tight function to it at the level of the epithelium. And in the breast tissue specifically, these are contractile, so that when the milk comes in, it will continue to propel the milk forward. Okay, so that will assist in that. Without this, you can have the milk to be stagnant in the ducts and then thus back up into the lobules. And again, you could have milk stasis and then infection to come from that. So what we're having in this disease, without vitamin A being present, you are basically not allowing these columnar luminal cells to turn into columnar cells, and thus you're having a metaplasia. Remember, metaplasia just means a changing of the cell type. A metaplasia, so a changing. And what type of metaplasia is it? It's squamous metaplasia. Remember, the squamous cells are just real flat cells, and their primary purpose is really just as a barrier. They're very good you usually stack them many times on each other, and then that's called stratified squamous when you see many layers of these flat pancake looking cells, and they do very good to protect and as a barrier. Well, that's not going to give us the function of columnar cells that's common for helping with secretion, reabsorption, and whatnot, and it will alter. When you have that, you are then going to begin to lose the function of pushing this milk out because the myoepithelial cells aren't as good at operating with squamous cells versus the columnar cells here. So you begin to have milk stasis in this situation towards the front of it. And then that trapping of the milk behind the squamous cells is what causes the infection and inflammation. And that's where the bacteria and all that begin to sit when you have stasis occur. So that is kind of how this whole disease works. So I know it took a while to explain all of that, but I feel like it is easier to remember this stuff when you kind of see it in a visual representation and hear the entire story of it. So now, what is the treatment for all of this? The first line treatment is self-resolution. That means it's going to self-resolve in most cases. But if it does not self-resolve, then you give antibiotics. Okay, and just like we talked about earlier, you can give various antibiotics in this particular situation, but if it's Staph aureus, you'd probably want to give dicloxacillin. Okay, but that's usually more linked to mastitis. So then, if that doesn't work, if it's still, even after antibiotics, if that doesn't work, then you think of more serious surgical techniques and you do something called a fistulectomy. That's just where you literally make your own fistula. Do you remember when you have a pathological fistula? What a pathological fistula is in the body? A fistula just connects. Say you had two parts of the colon, and it's all wrapped up in your stomach. And you have some sort of GI problem, whether it be Crohn's disease or ulcerative colitis or whatever. Let's just go with Crohn's disease, because Crohn's disease has a very high level of fistula formation. The damage from the Crohn's disease will begin to eat away and destroy the wall of the colon. Now, this is kind of happening kind of all over the place in that general location where this bowel is. Say it was connected right here. And it eats away, and then eventually it opens up, and as it opens up, the broken pieces kind of start to form with each other, and that has now connected in a place where it's not supposed to. That is called a fistula. And you can have examples of what's called AV fistulas, where you have an artery and a vein that will do the same thing. They have some sort of damage, and they will form together, and it destroys the blood pressure gradient. But that's for another video. That's all besides the point. So that's what a fistula is. And so this is why in this situation you deliberately produce a fistula, and you make a fistula to help drain the milk that is sitting static and not moving, basically deep from the block where the squamous metaplasia was occurring. So say this is the end of the duct right here, and we had this squamous metaplasia. You then would make a fistula to help drain this milk out so that the infection doesn't just sit in there, and then you're basically collecting bacteria and inflammation and all that. So that can help fix it, and that is a surgical technique called the fistulectomy. So we're going to move to the next one. This is mammary duct ectasia. So mammary duct, we're referring to the mammary duct. That's the first thing I want you to look at. Ectasia just is a word meaning dilation. If you can't remember that, just look at the E and think of extends. So it's going to extend in diameter. So basically what you have, say this is the normal kind of width of a duct. In this particular disease, your duct may do something like this. It gets too wide, and now the myoepithelial cells that are down underneath the luminal cells, say there's all myoepithelial cells right here, and then of course the columnar cells are on top. Now, because it's so wide, the milk just kind of sits in the middle and is stagnant because it can't contract it enough to bring this down and to get the milk to be propelled outwards. That's mammary duct ectasia. Naturally, with milk stasis, we talked about it earlier, anytime you have milk stasis, you begin to have a backup of milk in this direction more deep in the breast, and then you have inflammation and infection. So they thinking this is due to aging and long-term myoepithelial strain. So in other words, what this statement is saying is, well, what's causing this duct widening? Well, they really don't know for sure, but they have a couple proposed ideas where they're saying aging plus long-term myoepithelial strain on the ducts then stretches out and widens the ducts, causing stasis of secretions. That's just stasis of the milk, right? And chronic inflammation because of that. It's chronically inflamed because this isn't going back to normal. It's staying like this for years from the time it happens. So because of this, or I'm sorry, not years, say weeks to days to weeks to months, but it presents as a chronic inflammation. So there's a very characteristic discharge in this. It's green-brown discharge. For whatever reason, it's all of that, the debris and the backup and whatnot that's happening in this particular example causes a green-brown discharge from the nipple. So you're going to have a firm, painful mass under the nipple. That's possible, but not always the case. But if you have a mass, this is kind of high yield, because notice it says firm. And when you think of a firm mass, especially if it's not moving, you really begin to think of cancer. So a lot of these, you're going to notice, especially the next one, you can very easily confuse these with breast cancer. Keys like maybe a painful mass may sort of help, although there's weird examples of breast cancer where you have pain, a sign of inflammation in the breast cancer as well. So what's the treatment for mammary duct ectasia? The treatment, again, it should look very similar as the previous slide. Self-resolution. So this will usually self-resolve on its own. If it does not self-resolve, antibiotics. There it is again. Why? Because you have a chronic inflammation. You have bacteria building up with the milk stasis. If that doesn't work, then you have surgical excision. Okay? So in this case, the procedure is excision of the messed up duct, in other words. So here, the widened duct, we just need to excise the part where you have the mass with that chronic inflammation and fibrosis and whatnot. Okay, so that's mammary duct ectasia. The next one, and then the last one, this is the last one, is fat necrosis of the breast. You've probably learned about this. This is a very, there's two main types, at least, that I learned about when I was sitting in my early years of med school, of fat necrosis. So you hear fat necrosis in pancreatitis, and you hear something called saponification, where the fat is basically combining and being broken down and whatnot, and you're having calcium release that's causing calcification kind of all around it. So that's kind of the general idea behind saponification. But then in this particular example, in that one, it was pancreatitis that was causing that. It wasn't trauma related. In fat necrosis of the breast, it's trauma related. So trauma to the breast causes fat necrosis. Another example of fat necrosis, trauma to the breast. So this is trauma to the breast causes a sterile inflammatory process. I bolded. This is very important. How many of the other ones that I've talked about have not been sterile? This has been bacteria, that basically because of the milk stasis. This is all from bacteria, periductal mastitis, because you have that infection of the ducts under the nipple because of the smoking and whatnot and the vitamin A deficiency. In a breast abscess, this is due to bacteria, thus forming pus from the dead neutrophils. In mastitis, this is due to bacteria. Do you see how almost all of these, or if not actually all of them, are due? It is not a sterile process. It is a non-sterile process. You're having bacteria and pathogens and whatnot at the site that's causing the problem. In fat necrosis of the breast, this is not the case. You have some sort of trauma to the breast that usually the patient doesn't remember or doesn't even think about, and then it causes a sterile inflammatory process. So this is unique in this group of examples because it's causing inflammation, but there's no bacteria or bug or anything that's causing this. So what are the signs? The signs are necrosis. Okay, obviously, fat necrosis. It's telling you that tissue will necrose or die off. Calcification. There's the saponification. That's kind of very signature in fat necrosis situations. So there's the calcification because of saponification. And then you have giant cells on imaging. So remember, giant cells are also very characteristic for this fat necrosis. All right, and then this is important too, because this is where you may be tricked the most. Sometimes a firm mass is fixed to the skin and it can have skin retraction. and nipple inversion is possible. So this, just hearing that, you're strongly thinking of breast cancer. Any physician would. But especially if calcification is seen. So you're having this mass fixed to the skin. It is, in other words, it's not moving, it's firmly fixed, it's having skin retraction, nipple inversion, and now we look at imaging and you're seeing calcification. You're definitely thinking some sort of breast cancer. But when you continue to look, you'll find the necrosis and the giant cells, and that will differentiate that necrosis of the breast from some sort of dangerous malignant breast cancer. Okay, so I hope this video helped you, and I will see you in the next video on benign breast tumors. See you guys.